I'm a paediatric intensivist from Queensland Children's Hospital in Brisbane. I'd like to thank the organisers for inviting me to speak at this webinar, and I'd like to use this time to discuss our study, our paediatric infection microsampling, for which we are using capillary microsampling in our pharmacokinetic study of critically unwell children in the intensive care unit. I'd like to reiterate acknowledgement of country and of the traditional owners of the land, their connection to country, and their valuable contributions to Australian and global society. I'd also like to acknowledge the lab staff at UQCCR for their tireless work in giving us results, and for the group of research nurses at the Queensland Children's Hospital ICU, led in this project by Louise Sparks, for their tireless work in recruitment and completing recruitment paperwork and sampling and the like. I have no conflicts of interest to declare. So I'd like to just review what I'm about to talk about. So I'm going to briefly discuss pharmacokinetic concerns and critically ill paediatric patients and the background to that, and then briefly touch on the paediatric infection microsampling study that we're undertaking. So this is our paediatric infection microsampling study that forms the body of my PhD that I've started mid-career, with supervisors being Dr. Susie Parker, Professor Jason Roberts, Professor Jeffrey Lippman, and Associate Professor Mark Coulthard. And I'd like to acknowledge and thank them for their tireless and unending support, and additionally from the Queensland Children's Hospital Foundation. So this started a number of years ago when we were looking around at sampling and pharmacokinetic information relevant to pediatrics. I come from a group that has a strong focus of pharmacokinetic modelling in adult ICU patients, specifically around antibiotics. And we looked around to see if there was any good information or any new information in the literature regarding children's critical illness in children. And what we found was a big knowledge gap, and also some concerning trends that, following adult trends, that dosing schedules were not quite meeting the mark. There was evidence that this was the case potentially in children, and that's where we all started in this particular study. So as part of that systematic review, we found 31 articles of interest relating to critical care pharmacokinetics in children, and as you see, very sparsely spread amongst the common antibiotics that are used in children. And further detail, as in the next two slides, I won't go through all of those, but what we found was that either there was not enough information to inform dosing, or when there was enough information to inform dosing, there was alarming trends suggesting that dosing schedules in currently prescribed manuals were not meeting pharmacokinetic targets when these drugs were studied in detail. And in 2019, researchers from Great Ormond Street, University College London, Evelina Children's Hospital, and a number of other groups looked at the antibiotics that were on the WHO essential medicines list. So it's 28 antibiotics, and this chart covers lists all of the studies known since the 60s through to May 2018 of studies with respect to antibiotics that could reliably be used to inform dosing. So there's pharmacokinetic information held within those studies. And as you can see, there's very few studies spread across a wide number of different antibiotic classes. You'll note that vancomycin and gentamicin have been studied quite intensely. This primarily is around therapeutic drug monitoring rather than pharmacokinetic analysis, though they have been used to inform on dosing with some degree of reliability, but they don't allow for applicability to varying different groups with varying different pharmacokinetic profiles. So the conclusion there is that more studies with more reliable data and a wide range of illness states need to be undertaken. That antibiotic research in children is needing specific focus, and our aim is, with our study, is to add to that body of information within the critical care framework. These studies listed here are all studies, so include critical care, but not are specific to critical care. So only a fraction of those studies would have been undertaken in children that are desperately unwell in the paediatric ICU. And how did this come about? Well, basically, lack of regulation pressure at the time that these drugs were being introduced into the market, and unfortunately, antibiotics in children is not a financially viable target for research. So there's very little research coming from Big Pharma. This has been acknowledged as an important issue to correct for further registration of drugs, and there's been increasing legislative pressure over the last 2 decades to try and rectify this, but this unfortunately won't help for the antibiotics that are currently being used at the bedside. So last year this review came out and they identified 50 articles, and unfortunately their conclusions were similar, that majority of articles have focused on therapeutic drug monitoring, so looking at peaks and troughs and toxicities rather than looking at pharmacokinetic profiles that could be used to target prescriptions across a wide range of physiologies and ages. And they also identified that there was very little quality data in children, and where that data exists, it alarmingly points to the fact that dosing schedules currently being used are not reaching pharmacokinetic targets. They are therapeutic, but are not reaching targets. So potentially there's scope there to either increase the efficiency or efficacy of our dosing regimes. And last year, the Lanza Lake microsampling workshop produced a position statement that microsampling should be pushed to provide and bridging studies should be undertaken to broaden the applicability of microsampling, and we feel this is probably the best quality support we could get from the microsampling community to support research in our area, which is pharmacokinetics and critically unwell children. One of the issues in studying children is the ability to get sampling, and we feel that microsampling is probably the way to go to allow easier sampling. So samples from the skin, for instance, by capillary capillary sample, 10 microliters, versus needing to have an indwelling intravenous or intraarterial catheter. Obviously preferable, specifically when children are not in the ICU or not at the disease acuity to require sampling lines. Not all of the children in the ICU have lines that can sample, and we frequently use capillary sampling for a number of different indications in our less acute children. So again, antibiotics are prescribed in massive numbers in children's ICU. They're in this study from Hospitals for Sick Children in Toronto, over 10 years of admissions, 17,000 admissions, shows that antibiotics are the second most prescribed class of medications, and probably the first most prescribed class of disease-modifying agents, electrolytes, diuretics, benzodiazepines, sedatives, and neuromuscular blockers that are the other bars around antibiotics, are all drugs used to affect intensive care and have little role in disease modification other than supporting, allowing supports, intensive care supports to be implemented. So we prescribe a lot of antibiotics in the pediatric ICU, and somewhat routinely and somewhat blindly. Additionally, with worsening critical illness, there is a wide variety of changes physiologically within the patient, and this has been looked at in a significant amount of detail by researchers within our group who have been researching in the adult ICU sphere. So Professor Jason Roberts has been active in this area for some time, and this chart comes from an article discussing the difficulties of pharmacokinetics in adult critically unwell patients, and this would be very much similar for children. We have altered hemodynamics, fluid balances. We have altered clearances by deranged renal function and augmented renal function at the beginning of illness, and also liver disturbance and a variety of different supports that will affect the metabolism of drugs. So I would like to just sort of highlight some of the issues that other researchers have raised, and some of the information that causes us concern about our dosing regimes that we're currently undertaken in the ICU. So today in the ICU currently we routinely use intermittent dosing with schedules that come from papers that have very few patients and very few samples, and are not as applicable as we thought to the population of patients that we have in the pediatric ICU. So de Kock et al. Studied piperacillin, tazobactam, and 47 patients in the ICU, and created a model with a combination of allometric and maturational scaling factors, and tested their model with a variety of dosing regimes, and the results unfortunately reiterated what we've been suspecting all the time, that with current dosing schedules we are not reliably meeting pharmacokinetic requirements for thresholds. So what they did with their model is they ran an analysis, a simulation with the majority of different dosing schedules, and looking at different intervals and doses compared to continuous infusion on the right hand side. And what they found was that due to clearances in critically unwell children, it is very hard to achieve target therapeutic concentrations in intermittent dosing. And the graph on the right, as you'll see, a flat line across the top at the 100% target concentration mark, which is 50% of time above MIC of Pseudomonas aeruginosa, which would be a typical organism to target with pip/tazobactam. And so that sort of lends support to the fact that continuous infusions that are used with somewhat rare occurrences in outer ICU, but with increasing incidence, and particularly severely infected children or children where we're particularly concerned about target concentrations and the influence of altered pharmacokinetics, such as renal replacement, for instance, or ECMO, or burden of infection requiring high therapeutic levels. That would be probably at the current moment the only time we would look at continuous infusions, though there's evidence from this and many other papers that continuous infusions probably are superior to intermittent infusions if we're targeting pharmacokinetic parameters such as time above MIC for specific organisms. So Beranger also studied children in the ICU looking at cefotaxime. Cefotaxime is a widely prescribed third-generation cephalosporin. It's on the WHO list of necessary medications for children. It's used extensively across the world. Looking at 49 children and creating a model that was externally validated. So that model included allergenic and maturational factors, and her conclusions and the group's conclusions were that as a rule, intermittent dosing was not achieving targets and across the age group. And if you look at this chart and the different colors, you'll see it's actually quite easy to achieve targets. So that's a probability of attainment of 100% for an MIC of 0.5 milligrams per litre, which is MIC targeted at Citrobacter. So it's quite easy in neonates to achieve targets because of the immaturity of their clearance functions, primarily their renal function, but also their hepatic clearance. But as children grow and develop, clearances improve and become closer to adult type clearances. So then it becomes harder to attain targets. And as you can see, with the different colors, if increasing ages show different proportions, and the older, tending to be older children tend to not achieve targets as reliably. And the graph on the left is percentage target attainment of 1 MIC, and the graph on the right is percentage or probability of target attainment of 4 times MIC. And you see easy for neonates to achieve that, but for children older, this is not really achieved until the institution of a continuous infusion, and that's what the CI on the x-axis alludes to. So Q4 hour, Q6 hour would be reasonable sort of dosing schedules, and this is 100 milligrams per day. So that causes us some concern, and we've known about that for some time, and we've also accepted that for some of our patients we really need to consider the institution of continuous infusions, but we would like to know how much of a problem that is across the board, and specifically for our patients, are we attaining levels or are we not, and what sort of pharmacokinetic parameters should we be concerned with. So that's the idea for our study. Additionally, we're looking at the ability of microsampling to assist or facilitate in the collection of blood. Not all of our patients have lines that can aspirate blood, and also we wanted to try and broaden the applicability of microsampling to patients that have no access, such as those in the hospital wards or out in the community, and give a broader understanding of how microsampling might be useful in that sort of situation. So this is where I work. That's the Children's Hospital, Queensland Children's Hospital in Brisbane. We're 359 bed hospital, 27 active ICU beds. They often have more patients than that, and we routinely admit on approximately 2,000 patients a year for a variety of different acuities. So the problem was for us in the infection microsampling study that we had a wide variety of ranges of weights, age and acuity, and we were concerned at the ability of our current dosing schedules to meet the targets that we were expecting. And so the focus of this research was to actually analyze that question using data from our own patients and modelling using the commonest antibiotics that we use. So that's 7 antibiotics: cefotaxime, piptazepam, meropenem, flucloxacillin, capsolin, vancomycin, and ceftazidime. And additionally, we wanted to co-sample with macrosampling, so venous or arterial blood, with microsampling from capillary, and we're using capillary skin pricks as a proof of concept that we can get reliable data from that, rather than just using microsamples from a blood sample that's drawn from an indwelling arterial or venous cannula. So these are some preliminary results from KIFSOL, and this is approximately 15 patients worth of information showing the pharmacokinetic profiles of KIFSOL taken by conventional CON sampling and capillary microsampling, and shows on a timeline, concentration timeline, a good degree of reliability between the tests. And similarly, using linear regression, apart from a few outliers, we have a good fit, and Bland-Altman plots show the degree of variability within the 20% range required by the FDA for applicability and validation of a sampling analysis. So we're pretty heartened by those results. They're preliminary, but we think that there's enough information to support with that bridging study the applicability of microsampling for pharmacokinetic analysis in KIFSOL, and we expect that our further results will hopefully show the same, and they will be coming out as results come through in the next year or two. As part of our study, we also undertook a consumer involvement or consumer assessment, and we sampled 50 of our patients' parents to get their angle on the acceptability of microsampling. So don't forget, we're doing capillary finger prick sampling on patients that have different degrees of wakefulness in the ICU. Some are not intubated or asleep at all, some are slightly sedated, and some are heavily sedated. And we don't have that information here, but across the board there was general acceptance that capillary microsampling was a reasonably acceptable thing from a consumer point of view to undertake. And if one were to compare it to, say, a venous stab, and most of the children that have been in the ICU that were in this study would have had previous venous phlebotomies for the parents to have reference on what alternative types of sampling might require. So that's where we're at. We're halfway through recruiting for our PIMS study. Unfortunately, COVID has upset our recruitment somewhat, and the ability of the nurses to be in the ICU actively recruiting. There have been a number of other issues that have worked against us in terms of recruitment that are organisational in nature. But we're hoping to complete the current study in the next 12 months or so, and hoping to publish results on all of our bridging studies and antibiotic classes. In terms of where to go from there, ideally we would like to bring the modelling to the bedside, and there are two other investigators in my ICU that are investigating the pharmacokinetics of antibiotics in critically unwell children. So we're looking at creating a body of work that will greater inform our dosing across the spectrum, across low acuity and high acuity. Ultimately, we would like to bring in point of care testing with antibiotic levels and potentially other significant drugs. I think this is going to be the future, that we can have real-time testing, so we can target and individually dose our children with appropriate doses. So we're actually using some degree of intelligence to target the antibiotic levels rather than just looking up a book and taking somewhat of a stab in the dark, using a dose that isn't necessarily validated for a child in that particular health state or physiological imbalance. And in the future, I could see this type of analysis being used for other drugs, and other significant drug class that we have trouble with in the ICU is sedative drugs and analgesic drugs. So although target concentrations are probably less easy to discern, I think there's another area in our specialty that needs particular attention, and microsampling could certainly be an important arm of investigation there. So that's all I have to talk about today. So thank you for listening, and I'm just wondering if anybody has any questions. I'll be online at the end of this presentation to receive any questions or comments. Unfortunately, I was unable to give the presentation live because of network difficulties where I'm currently staying, which is at Alexandra Beach, about 120 kilometres north of Brisbane, and that's a lovely photo of the sunrise over the beach that I took a couple of days ago. So thank you, and thank you to the organisers.